Welcome to Let's Talk Micro.
Hello, everyone. Welcome to another episode of Let's Talk Micro. As always, I hope you had a great week. You can always find Let's Talk Micro on Apple Podcasts, Spotify, Google Podcasts, Amazon Music, TuneIn Radio, Overcast, Pandora, Stitcher, Good Pods, wherever you listen to podcasts, you can find Let's Talk Micro. As far as social media, I am on Instagram as Let's Talk Micro, no apostrophe on Twitter as Let's Talk Micro 1, on TikTok as Let's Talk Micro, and on LinkedIn as Luis Plaza. So please go ahead and subscribe to the podcast. And if you subscribe and you listen to episodes and you like them, go ahead and leave a review. That's always good for the podcast. So subscribe to the podcast, follow me on social media, provide any feedback, any possible podcast topic suggestions. I always like to post pictures of organisms and give updates as to when the next episode is coming out. So definitely go ahead and subscribe. Any feedback, any topic suggestions, they are always welcome and appreciated. And I'm not going to talk a lot today because the episode is long. But if you haven't checked out the previous episode, go ahead and do so. It was with Andrea Prinzi. She's a microbiologist, and we talked about an article about microbes in your food. So we talked about Enterococcus and feta cheese. We talked about Fusarium and how it plays a role in a popular meat substitute. It was a very fun conversation, very educational. So go ahead and check it out if you haven't already. So today's episode, it was one that was definitely great. I had a great time recording it. It was very good. It was long, but the time just flew by. It was so interesting talking to this person. As I always say, I enjoy connecting with microbiologists, with laboratorians, and this time I also got to connect with definitely an infectious disease doctor, that's involved in this field, but at the same time, a podcaster. Maybe some of you have listened to it already. If not, I definitely recommend it. The podcast is called IDIOTS, or idiots, but it stands for Infectious Disease Insights of Two Specialists. And it is spelled ID:IOTS. So Infectious Diseases Insights of Two Specialists. But altogether, it reads idiots. So I had a chance to chat with Callum, which is one of the co-hosts. This is hosted by Callum and James, and they are two infectious disease doctors in the United Kingdom. And their goal is very similar to mine, of my podcast, which is, they want to share information, they want to educate. So they enjoy doing it. They do the research and they put information out there in a responsible manner, which is what we always, as communicators, we need to do. Unfortunately, due to some unforeseen circumstances, James was unable to make it. So I got to chat with Callum. So James, definitely I'm looking forward to talking to you the next time. And they extended an invitation to their podcast. So I'm definitely looking forward to that. So let's go ahead and check it out. Like I said, it's a long episode, but it's worth it. Let's listen to it. So one of the great outcomes of podcasting, and I have said this before, is that I get to connect with people from this field, fellow educators, fellow microbiologists, fellow medical laboratory scientists. So it has been great. So today is no different. I get to connect with someone that works in this field and at the same time, a fellow podcaster. You might have listened to the podcast before. It is called IDIOTS, or Idiots. One of the co-hosts of that podcast, I have Callum. Callum, welcome to Let's Talk Micro.
Thanks very much. Thanks very much for having me, Louis. And we were making a joke there because in the UK we pronounce cephalosporins with a hard K, and I know that over in the US it's soft C cephalosporins. So I guess my name would be Callum here, but it's actually Callum. So I guess my name is pronounced in the American fashion.
Yeah. So it's Callum.
No, it's Callum.
It's Callum. Sorry.
I'm
Yeah,
confusing you now.
yeah, a little bit. No, yeah, I think that's what. Yeah, that's why you talk about the cephalosporins, and we'll talk about the podcasting a little bit. But that was one of the first things, like I saw the name was the first thing that drew me to it when I saw it. So I started looking at it, and then I saw what you did for the podcast. And the first episode that I listened to was actually about the cephalosporins.
Oh,
So imagine when I started listening, I think I downloaded it and I was listening to it on a flight. And then when I hear, like a cefepime, ceftazidime, ceftriaxone, I'm like, wow, like they pronounce them like that over there. And I shared that story with a coworker, and he was like, really? Like, wow. So it was just, surprising, like hearing that pronunciation. But I definitely, I do listen to your podcast, and we'll talk more about that. But let's go ahead and start with a quick introduction.
okay. My name's Callum. I work in Scotland. I'm a trainee in both medical microbiology and infectious diseases. So the way that the training works here, it's changed slightly in the last 10 years or so. But now we have the medical side over the laboratory, but also we combine that with the clinical side on the wards, doing infectious diseases. So I've been in training since, well, I started medical school in 2007 and qualified in 2013. And I've got 2 and a bit years more left before I would become a consultant or the sort of attending equivalent. So I guess I'm a resident equivalent or fellow equivalent. Trying to get my head around the American system. At the moment, I'm actually doing a medical education fellowship, although that doesn't have anything to do with podcasting. It has been really useful to learn a bit more about things to do with education and educational theory.
Okay, well, definitely, welcome again. As infectious disease doctors, definitely we, at least here in the US in the laboratory, there's not that much interaction. They more maybe they will interact more with our medical director or our doctor microbiologist. So we typically, from us working on the bench, a lot of times, what we see is the request, or maybe on the phone requesting some results on a culture, or maybe adding an additional susceptibility. So can you tell the audience, what do you do as an infectious disease doctor?
Sure. So I think the roles in the UK anyway of the medical microbiologists and infectious diseases doctors is merging. The traditional role has been like a couple of different silos of practice. So I guess imported infections, things like fever and returning traveler, tropical infections, things that are like unusual and outside of the scope of your general physician in like internal medicine. So that's been like a real part. So like, your malaria, your typhoid, these sort of not rare but not common infections we take on. And I guess what those infections are depends on the setting. So London has a whole load of, malaria is much more common there than it would be in Scotland, for example. So sort of the practice differs. And another like key area, I guess, would be care of patients with chronic viral disease. So hepatitis and HIV would be like a core area of practice. And that's, I guess, been like, pre-antiretroviral therapy was a huge amount of work. And now it's more sort of chronic patient care with hopefully rarely having patients with more advanced HIV or AIDS. And I guess emerging areas of practice is a lot to do with antimicrobial stewardship and, responsible use of antimicrobials, antibiotic resistance, and then outside of those, kind of core areas, we do a lot of work with more unusual, the really complicated cases. I think that's where we lie. And our sort of model for delivery of infectious disease medicine is in the UK, certainly it's mostly in what we would call like a tertiary referral centre. I don't know if it's the same, but like, the teaching hospitals attached to university, and there's less presence in our sort of smaller hospitals out and about. And we have, certainly in our local area, we have infectious disease wards. We've got inpatients that we would look after, usually with sort of complex, difficult diseases. We run a lot of outpatient clinics. And then the other way we deliver care is we do like consult services where we go around other wards and see patients with bacteremias or complex infections. And I guess, fundamentally the difference between the UK and US health systems, because in the UK, like for these consult services, there's not like a fee attached. Like, so each bit of healthcare, nobody's paying for the healthcare. So it's not like we get any benefit from doing that other than obviously benefiting patient care. So there is a lot more pressure on services to be judicious with our resources about what we do and don't deliver, which is a real challenge, because I think, it's like 30% of hospital admissions have an infection. So the real challenge with infection medicine is which patients really need input from an infection specialist, because you could take on a whole lot of work, but do you need to do that? Where is it most impactful?
Okay, yeah. I see. Definitely, yeah. It's a lot of work. I mean, from what I've seen here, I mean, I know I work in a large lab, and there's definitely always a lot of cases and a lot of consults for them. So they do stay very busy. So one of the things, in microbiology is just like it's a field that it's always changing, and especially, when you're working and as a medical laboratory scientist, which is a biomedical scientist over in the UK. Definitely, just the organisms, they're constantly changing. We're always surprised. We always like to say this, these bugs, they just don't go to school. They do whatever they want, and you learn something, and then next thing you know, you find a different morphology. You find them maybe in a different and a surprising source. So as an infections, as far as as an infectious disease doctor, what are the most common organisms that you work with?
I think one and probably two is Staphylococcus aureus. That's like a mainstay of our practice. Patients coming in with complex Staphylococcus aureus bacteremias or other disease is huge. And I think other organisms, strep pneumo would definitely be up there. Like, your just common bacterial infections are making up the bulk of disease. Gram negatives, and I guess it depends on like your local setting and what specialties you have. What your area of practice is. I guess Pseudomonas would be another big factor in hospital-acquired infections. Now we're very fortunate in Scotland in that it's a small area of the UK. The population is about 6 million, so pretty tiny in comparison to lots of areas of the US, and that means that we can have quite unified practice. And we also we don't have huge issues with antimicrobial resistance compared to a lot of areas. So although we do see patients with like carbapenem resistant Enterobacterales or multi-drug resistant Pseudomonas and so on, that's rare still, compared to a lot of parts of England and where there's a lot more imported disease. There's a lot of problems with multi-drug resistance organisms. So we're quite lucky here that that's not a huge problem. It's not to say that it's not going to be, but I think part of that is to do with quite robust stewardship programs, and also just to do with population dynamics.
Yeah, that makes sense. And then typically, probably, depending on the population, and because sometimes, I have worked on smaller hospitals where the population, you don't see that many multi-drug resistant organisms, but then on the hospital that I worked in, a large city, you see more, and it's been increasing over the years. Like I remember when I started, maybe you will get the one case of a carbapenem resistant, of a KPC, and nowadays, you see more and more. So it's definitely been on the increase. So that was going to be my question, and you answered it. So,
sorry.
No, it's okay. to tie up about the organisms being unusual, and we've always been surprised. So now you mentioned the most common ones. So what are some of the most unusual organisms that you have seen in your career? I mean, if you are able to talk about it at all.
Yeah, I guess, some of the things that we get here are probably not that unusual for people in other parts of the world. And and I don't often get the opportunity to look at the organism on the plate or directly, just because the way that we work cross-site and so on. Because I mentioned a lot about what the role of an infectious disease doctor is, and essentially, I don't know if it's similar to the US, but the medical microbiology role is much more lab focused in terms of laboratory management, results coming out, occasionally having a bit of input into the lab, but that's becoming less common because it's becoming a more clinical role and doing some of that consult role. But a lot of it is taking advice calls, so getting referrals by phone or going to see them. So yeah, the unusual organisms that I've been involved with, I guess, it's probably the things that stick in my mind are the tropical infections, because that's just more unusual. So I think quite early on in my training, I was looking after a patient with leishmaniasis. And I think that really stuck in my mind. Like, it was cutaneous, and there was an ulcer, and the treatment was really toxic, and it was quite a difficult thing to do, and the diagnostics was quite unusual. So that was really stuck in my head. And then we've had some other unusual things going on. So we've had I've not been directly involved, but we did have an outbreak of anthrax in our injecting drug user population. So it was thought to have been contaminated at some point during the transport chain, and it was mainly focused in Glasgow, which is a city in the west of Scotland, and there was cases elsewhere as well. So that's something that we're very vigilant about, because that's obviously a very dangerous pathogen to have in your lab. A couple of weekends ago, we had an organism that we thought might be Bacillus anthracis, but thankfully it was something else. So sometimes it's the organisms you don't get. Other things that stuck in my head are like Crinibacteria diphtheriae, so diphtheria, which was quite mild actually. And again, I wasn't like directly involved in that case, but in a small center, well, it's not that small center, but you know how people, you hear about unusual organisms and go into the lab and see them if they're there to be seen. So
Yeah, we do, and especially between us, like biomedical scientists, and we definitely, if we see something unusual, we make sure that or we hear that it's like people talk, and then we go, oh, I heard that someone had this, so you go to the person and you approach them, and typically, for teaching purposes, especially if they're unusual, we try, as long as it's not dangerous to do so, but we try to maybe subculture it and then show it so people can have that visual and recognize it. If they ever get it again, then it's a little bit easier for them. But I can.
yeah.
Mhm.
Oh, sorry. In medical education, there's this term for like high acuity, low. I can't remember what the O stands for. It's called HALO, and it's a term for training about things that when they come up are really important to know about, but the low occurrence, I think that's it, and it's really important to train for these unusual organisms, because it's really key that you can identify them when they come up. And that's a big challenge to training, is like, what's the balance between safety? You might be the first person to see that, and you need to be able to pick up what the organism is.
Yeah, definitely. I agree. We need to be prepared, and I always, that's what when I teach other techs, or it's always definitely first, you start with getting a good grasp on what's normal, right? So that way you definitely know if something is off, in the back of your mind, something goes off, and okay, maybe I should bring someone else in on this, or ask, or look at a textbook. But definitely what you said, because you don't know who's the first person that typically, and maybe the incidence of having an anthrax or a sample with the plague, they're very low, but you don't know if you're going to be the one opening that plate and looking at it. So definitely need to be prepared and educated enough where as soon as we see this, we know something is off, we proceed with caution, and then either consult with someone, take the proper steps, but don't expose everyone in the lab. So
Yeah, it's funny that a lot of the time there's a huge amount of skill in reading those plates and, identifying just from a glance, like, oh, that's going to be this or that. And sometimes there's things that don't quite fit into our sort of pattern recognition of what it's going to be. So, you could see a bacillus on the plate and think, oh, it's just it's going to be bacillus, or it might be, looks like some other gram negative. and discount that unless you know the clinical history of the patient, which I don't know how it works in your centers, but here we really struggle to get useful information on the request to the lab. So quite often there's no clinical details of the case. So you don't know the patient's an injecting drug user, has been off traveling, and had lots of contact with animals.
No, yeah, it's the same here. Sometimes we have to dig a lot and trying to find either, like in the patient's chart, just getting there and try to find out, okay, because sometimes, especially you get let's say you get a swab and all it says is wound or it says abscess, and you're like, okay, from where? So typically, first instinct is you go to the actual sample and you look at it. Maybe it's written there on the label, but a lot of times it's not there. So then you try to find the patient's history, and then it's not documented. You're digging through all the dates and you finally see the date that matches your culture. And they're like, okay, presents with this. And then, because sometimes even calling and asking, especially if it's between shifts or the sample was collected before the patient was transferred to that room, it's very time consuming trying to find that one, especially in my workday where you have definitely easy, you can have over 100 cultures to get through. So it's very time consuming.
I'm laughing and smiling, but it's incredibly frustrating. And why I'm finding this a bit funny is because is sometimes you think, is this just us? Is this our local center? People, but I imagine this is a universal problem. If there's some part of the world where they manage to get clinicians to put the exact details onto requests that you want, I want to hear from them, because how do you get people to do that? Even with forcing functions like on our electronic system, that it's mandatory to fill in some fields, but people just press spacebar or just write ... or something to get past that. And I think the issue at heart of that is that people don't understand how the tests are processed, and they don't understand the significance of the clinical information for, like, if the patient has got a sore throat, we might work up the samples of the swab differently if we know that they've got recurrent tonsillitis, looking for different organisms, or if they've got an abscess, But I think so few people understand how the test is processed and how the impact of the clinical details has for your job. And I think I'm not sure how we solve that problem. But I guess I'm not sure if I'm glad or not that you have the same problem. I would rather you had it sorted. Actually, that's probably that would be good.
Yeah, it'll be good to see how we can help reduce those issues, because they add up, especially when you're trying to do the best work and provide the best care, because after all, like I like to mention, we do this for the patients. And when you spend 30 minutes trying to track down something and so you could do your proper work, it's not only is time consuming and it's frustrating. So
Yeah, no, that's so true. Like, at the end of the day, it's having an impact, because if you don't know the details, you can't do the exact right tests, and then that has an impact on the patient ultimately if we miss something.
and one thing, just to before I move on to the next question, is just that another thing going to all this, there's nothing more frustrating as a medical laboratory scientist or a biomedical scientist that you're trying to call a critical result for like a patient that has been discharged, and you're calling 5 or 6 numbers and you cannot get a hold of a doctor. I don't know if you experience that problem over there, but it's just we tend to have that, especially if then once the patient gets discharged, you have to call a different number, and then you try that, and sometimes the on-call person doesn't want to take the result, and it's like, well, aren't you on call? The whole purpose of being on call is to answer the call, but
Yes.
so
Yeah.
that's another, but that's a whole separate thing. But it can be frustrating when you're trying to document that result, and these things, they have a turnaround time that affects the metrics. And if you get something critical, you're supposed to report it typically, within an hour. Some tests 30 minutes. So if you're trying to call that and spend 4 or 5 hours trying to get a hold of the physician, it can be frustrating.
Wow. Yeah, I don't know if that's as big an issue, just because of the way that care is organized here. It's very team based, and so the result would generally just go to. I don't think I've ever had that issue actually with someone not wanting to take the result. But I don't know, because the way that we work is that most of the kind of urgent results come to the microbiologist, and then they would communicate it if it was urgent. There's some situations where urgent results are phoned up by the biomedical scientist, usually if it's like the middle of the night, and it's like a neonatal sample or something like that. There's like a whole protocol we've got for it, but I do wonder sometimes if like if it's a medic to medic conversation, then you're less likely to get people refusing to take the call. But I don't want that to be the case, but I think there's an element of that there. I don't know.
Well, yeah, I mean, I think, yeah, as far as like we're the ones that call the results here, but when we do have either having a hard time or sometimes, especially when we have a like an unusual request or something that we don't typically do, or it's always we do definitely relay those to the our microbiologists, and then they do talk doctor to doctor, and then to find out, okay, do you want this, and or maybe give them some other options, or and then they work it out and they relay the information back to us. So that's definitely a big part of our work here. But as far as your routine, like positive blood cultures, positive cerebrospinal fluid, like we are the ones that do the phone call.
All right. Okay. Yeah, I think. Yeah, it sounds like that's quite different then. Maybe we need to change our model slightly, because there is quite a shortage in places of microbiologists. So I think maybe we'll move towards your model at some point. I don't know.
Okay, yeah, I think our microbiologist will be very busy if he had to handle that level of phone calls. He would not be able to do anything else. Okay, so I mentioned at the beginning, definitely let's talk about your podcast. Definitely it's nice to talk to another podcaster. You're kind of doing the same thing that I'm doing. It's just, slightly different because we do, help our patients, but we do different functions a little bit in the way that we provide that care. So let's talk about your podcast. How did this idea come about?
Yeah, so the podcast really came about. James and I used to work together before he deserted me, and I think we gave a joint teaching session to a group of fellow medical trainees, and really enjoyed having a sort of quite a light approach to it. And then when James left, I think I talked to him about, whether we should just do some more teaching and do some podcasting. And I think that what we were targeting is that to do infection medicine in the UK, there's a series of exams it's like the fellowship, the Royal College of Pathologists, and there's two parts to the exam. There's part one that all the ID doctors and the microbiologists have to do, and it's a second part which you only have to do if you're working in the lab, if you're a virologist or a microbiologist. And so we sort of focused it around, okay, so for people sitting that first exam, which is basically all of infection medicine to a sort of moderate level, what resources are out there? And there's a couple of books and revision tools, but there's not that much. So that's where the gap was. And we thought, well, why don't we target that? And so we started from there and have sort of gotten into a little bit of a rhythm talking around bacteria mainly, and trying to link up the lab and the clinical side. So I think that's how it started. James might remember it slightly differently, but unfortunately he can't join us today. So if you're listening, James, sorry if I got anything wrong.
Yeah, okay. As far as podcast definitely does have its challenges, and I mentioned mine in some interviews about it can be time consuming, it can be getting prepared, some of the logistics. So any challenges that you have experienced with podcasting? What has worked well, what hasn't?
Yeah, it's so true. I think the main challenge has been like sustaining momentum. When we're actually meeting and talking, like you and I are now, like that's the joy of it, is the conversation, the creating of the content, and that bit's great. I think the bits that are challenging is preparing, because we were talking about this before we started recording, and you really want to make sure that what you're putting out there is factually correct. You don't want to tell people the wrong thing. And so the preparation stage is quite a lot of work, and then the editing as well. So the way that we work it, and we've kind of come into this naturally, I guess, is that I've taken on more of the editorial role, and James has done the preparation. And I think that the challenge is really just finding time to do that and committing to it. And sometimes we've had little bits of gaps when things have been going on outside of the podcast. Otherwise, I think, we'd quite like to move into having guests on, because I think the nice thing about having a guest is that it's much easier to bring someone in to talk about something than have to go off and learn it all yourself and prepare. So that can be a nice way to just share information. Like if someone else knows it, then it's much easier to just ask them the question than have to go off and become an expert in it yourself, which is one, probably not possible, but two, also a lot of work.
Yeah, I definitely agree with that. I mean, just with as someone that, like I host mine, it's just me, and then the whole process, definitely getting prepared and then talking, and then just not alone letting you talk about the editing. So it was definitely challenging listening to my voice for 25 to 30 minutes. I'm like, oh,
Yes.
like I didn't know that I said or I, so it's like I editing that portion. But definitely the interviews, they tend to be easier because, yeah, like in my case, I do, if I read the article, so I just write some key questions and then I just send them to the guests, and then so they do most of the talking. They talk about their subject, their article, and then you kind of just build up on it or mention a few notes here and there. Yeah, rather than going for a full 30, 40 minutes, talking by yourself. Yeah, it's just, so the interviews are definitely easier in my opinion. So now that you mentioned the,
Another thing I think is,
yeah, no,
oh,
no, go
sorry,
ahead. Go ahead.
I thought you were. I think another thing that's really challenging, and I don't know how you feel about this, is imposter phenomenon, because you're obviously putting yourself out there in a very public way, and there's, let alone the sound of your own voice, which is a bit disconcerting initially, at least, and being factually correct, but also just saying, we're going to do this thing, we're going to share this information, people are going to listen to you. You don't know who's listening to you. You don't know what they're thinking. It's not a conversation, and that can be a bit daunting. I don't know how you overcame that, or did you have that at all? Or
Yes, I did, and I'm traditionally very shy, so just putting myself out there, that was a big challenge for me. And but yes, I do think sometimes, yeah, who's listening to that, and that's what for me it's just mainly trying to make sure that I put the information, the correct information. So if someone will, if it will get back to me for any reason, well, this is the resource that I use. So it's not me saying stuff that I have in my head that I have learned. Because sometimes you, like, one of the challenges that goes to the podcast is like maybe you do know the information because you have done it, you've been practicing, but putting it in the proper way and transmitted it to the audience. So you do need to do that research to properly use all the terms, not just what's on your head. So that's for me, that's the main thing. As long as I put the correct information, and I'm very clear. I mean, I'm just, like I said, I am a biomedical scientist with a big passion for this, and I love to teach and I love to talk about it, and that's it. So, but so far it's been
yeah, and that comes
oh,
across.
thank you so
So
much. Yeah, it's been
that's,
a very, very
yeah.
positive feedback so far. I haven't had any criticism, so that's good.
Yeah, constructive feedback, hopefully. But you kind of wonder as well, isn't it? I definitely would want, if someone listened to an episode and there was something we got wrong, I would want people to email in and say, this was actually this, and then you can correct. Because at the end of the day, as you said earlier on, we're doing this to educate and for the joy of it, and you want to make sure that things are right. And I guess that comes into like a side benefit of it, isn't it? That because you're having to prep so much and think about it, it has like I found this really helpful for keeping my knowledge up to date, and I've learned so much actually, mainly from James. I'm not sure James learned as much from me, but that's fine because he's more senior in his training, so that's to be expected.
I totally agree with that. Yeah, we definitely because you're sitting there and then you are reading and you have your textbooks or whatever. So it's like you're definitely reinforcing what you knew and learning more at the time. So you find yourself learning more, and it definitely helps. And like I listened to your episode about your senior, but I actually waited before because I released one, so I didn't. That's one thing when I listen to yours. If it's a topic that I haven't covered, I wait till I actually release it. That way, in any way, there's like no bias in my mind, or I'm not referencing to anything. So I do that. So I did my research, did my Yersinia, and then I listened to yours. But getting back to the learning, yeah, then I found myself when I was teaching the students, yeah, I felt so comfortable with the material and going through the organism, the diseases. So this whole process definitely has helped to have gained some more knowledge and reinforce what I already knew.
It's funny actually because I was listening to your episode on Yersinia when I was walking somewhere the other day, and what's funny is the flip side to learning a lot is that sometimes someone tells me something that we've mentioned in the podcast. They're like, "Oh, I listened to this and they talked about that," and I've forgotten it. So it's not like you like any other form of learning. Like, do you actually retain it? So sometimes I think, should I go back and listen to my own podcast? Because actually, you can learn all this stuff for the prep and then say it and then think, oh, I've forgotten that. So, but you need to just use the knowledge, don't you? So,
Yeah, I mean, definitely, especially if maybe it's a topic or an organism or something that you're not too familiar with. That definitely after a while, it's definitely good to go and reinforce that either by listening to yourself or if you're listening to someone that covered the same thing. Yeah, it's definitely helpful to every now and then, yeah, refresh. I mean, there are some things like with your staph and strep and enterobacterales. So in my line of work, those are very common. So those always stay fresh in my mind. But when you get to other organisms, definitely going back, it will be very, very helpful. So then again, talking about your podcast, so what is it about?
yeah, I guess it's about the title is Infectious Diseases: Insight of Two Specialists or Idiots, and I guess is about here the way that we're kind of approaching it from a slightly different angle because I think you can look at it from lots of different ways. You could say let's approach this from like a systems approach and say let's talk about urinary tract infections and then go into the organisms. Or you could approach it from the other angle and say, let's look at the organisms and then go into the clinical syndromes. And we've approached it like that because I think, certainly for medical education, most of the focus is on diagnoses and diseases and how you approach it, and there's very little knowledge about organisms. I think people have heard of them, but just can't link them up. They can't make a schema in their head of where organisms sit. They maybe see them on reports. They don't really understand it, and so that's why we came at it from that angle. When we have more training doctors on the infectious diseases ward, and I talk to them about a topic, I often find that the thing that they want to know about is the organisms. And so I spend a lot of time just going through staphylococci and streptococci, what is coagulase negative staph? And that's where the podcast is sort of taken off from, is those conversations that we had on the ward, which was trying to get people not like a deep level of knowledge, because as a medic, there's quite a lot you don't really need to know unless you're working in microbiology, but at least enough to feel a bit more comfortable with it when they see it on the report. And also to have a little bit of understanding of like, well, this is the antimicrobial regime we've chosen for this patient with this syndrome, and it could be these organisms. So if, say, we stop the gram-negative cover, then we need to replace that with something else, which, is quite complicated, which I guess is why my job exists, is that managing infections can be really complicated. So trying to just share that knowledge, I guess. Hopefully that answers your question.
It did definitely, and yeah, it is a lot of information. Maybe from anywhere from all the way from the disease, the organism, and the lab. There's like, yeah, it's so much information, and that's where, in my opinion, yeah, like a podcast, it comes in handy because it's just you put everything 20-25 minute format, maybe a little bit longer. And you can, repeat, re-listen to that. You're doing laundry, I don't know about, working out with micro information, but definitely riding on your car, doing some tasks. So you're multitasking, you put that information, and I always like to stress this, like not everyone has the time to go and read a journal or read an article or grab a textbook. We're busy people in the lab, we have families and just about getting through the 8 hours, and then the other job kicks in, which is, pick up the kids, homework. So definitely, but this, you can listen to it, your 20 to 25 minutes. And that was the goal of mine as well, just to educate people, and especially as fellow biomedical scientists, that, this job requires a level of confidence because it's a lot of information. And the way you get that confidence, it's repetition and knowledge. So that's what I found out, what I work the organisms, what I have seen, what works well, what doesn't. So I put it there. It's just about educating people. And at the same time, from listening to yours, I have, we talked about this before we started recording, but, I learned about what happens with the results that we put out. What's the regime? How do you treat the patient? So that's always good for us to learn as well, so we can, it reinforces what we know, and we have a better understanding of our work.
Yeah, I think, and this is something that we certainly struggle with, is that the work that's done in the lab is critical and is hugely important and has a massive impact on patient care. Whether there's a positive result or negative, that's hugely beneficial. But because it's not a patient facing role, you don't get that feedback. And I think one of the things that I find as a sort of clinically working doctor, like one of the most rewarding part of the job is having that patient in front of you and them saying thank you. And that just makes it all worth it at the end of the day. Like, you can have a really bad day, but all you need is that small token of appreciation, and that's huge. And it's funny because there's so much apparatus behind that interaction that the patient only sees the nurses and the doctors and the health professionals and the cleaners and the other people that are immediately visible to them, and they miss the radiographers, the biomedical scientists, the admin support, the IT support, like all these people that are behind it, without whom it couldn't work. And so I feel like I certainly, as a medic, feel some responsibility to take that appreciation and like that joyful part of the patient interaction back. And I don't know, like, if you have ideas about how to make that, like, I guess it's like making sure that everybody appreciates how important they are to the patient's journey through healthcare, and like how much that's appreciated, even if the patient doesn't know or understand what's happening. That has to be passed on.
I definitely agree. It has been some challenging times, in the lab, especially with COVID. So it's definitely, we don't directly deal with the patients, but it is definitely always nice when we get it, or a physician or on the phone, and then they say, "Oh, thank you for that," or "Thank you for the job you're doing." We don't do it for the praise, but it's definitely nice, to get that recognition. It is very involved work, and when we get that, instead of, because a lot of times, and maybe it might be due to the lack of understanding, which is also one big thing that hopefully, not only with my podcast, but maybe others out there, and that everyone can have a better understanding, just like we as biomedical scientists, with podcasts like yours, understand more about what happens, with the patients. The other way around, see that, everyone understands how the lab works, because sometimes, we do get those phone calls like, where are my cultures, or why hasn't this been done, or it's a time consuming process. And sometimes, especially with the training, if you put a request for something at a certain time of the day, if no one is trained for that, it's not going to get until the next day. And then, the organisms take time to grow. So it's just, microbiology is all about time. So you have to plan ahead when you're working. And sometimes we know, especially with the doctors, and we know who's going to request something. So we kind of start thinking ahead. But yeah, it's good for everyone to understand how how the process in the lab works, and it's just very time consuming and what we do. And that way, everyone can have a little more patience and understand. I mean, we work as fast as we can, of course, keeping in mind the importance of putting those results out there, as soon as we can, but we have to do it in a responsible manner.
It's so it's almost seems so obvious, doesn't it, that giving people positive feedback will help them feel motivated. And yet we work in healthcare in a setting where essentially the expectations are so high and it's so important that if you do a great job and you get that sample out within the turnaround time and there's no errors and everything goes to plan, nobody's going to come back and say, oh, like, great job on that wound swab. You picked up that Staph aureus. But they will come back and say, like, oh, the sample came back a day late, or, and we're constantly dealing with like quality management in the lab and, when things go wrong and that sort of thing. And that can be quite, I think, hard to process because, you're constantly looking at the things where things go wrong, and we don't spend much time on thinking these are all the things that we're doing really well and celebrating those. Or, as you say, like, it's that small thing, isn't it? It's just that, someone actually saying, oh, thanks for that result, like, and that sort of civility piece around making people feel valued, and or rather making them feel valued, which sounds a bit superficial, understanding that they are valued because they obviously are. And that's I think that's quite hard when you're removed a little bit. And so I guess that would be if any clinicians are listening, then I think that you have a sort of duty to do that to all groups who maybe don't get the benefit of being patient facing. There's definitely downsides to being patient facing sometimes, but there's a lot of upsides as well. So passing on that thanks, or if any patients are listening, send your lab a thank you note, because I think they would really appreciate it.
Yes, definitely. And just to talk about just real quick something that I talked about understanding of how the lab works, and it's always beneficial too. Like sometimes it happens. I don't know how it works in the UK, but sometimes we get requests for extending the cultures for an X amount of days, and for some reason, if we hold the account, I mean, I guess it's because they see that it's been finalized in the system. But understanding that if you finalize it and then if it's negative and then you discard your plates and then you get that request, you have to go and retrieve the sample and then go ahead and replate it. And at that point in time, you start thinking, okay, it's been 5 days since we discarded the plates, and then the sample's been in the fridge. It's a negative, like it's a no growth, because is it truly a no growth, or is it because the sample is not stable anymore? And a lot of these preservatives for the swabs, they have and they tell you, after an X amount of days, the stability starts going down by like 50% and it just decreases. So it's something to be good about. Definitely good to understand how the whole process works, on both sides.
Yeah, I think that's a good like example of something where you need to have a level of understanding. And obviously there are organisms which can be fastidious and slow growing, in which case you need to extend out the cultures. And the ideal way that would work is that when you're taking the patient samples and you put on the request details, the clinical details, then your standard operating procedure will be such that if the differential includes, like, I guess typhoid might be an example in blood cultures, you might want to extend the cultures a bit further. But also I think people need to have a bit of trust in the lab process and say, like, actually, with culture techniques now, with blood cultures, for example, they're really sensitive and they will pick up things. And rarely is extending cultures going to be that useful. And that's probably been thought about in terms of how long the cultures are kept for. So maybe it's going back to the people who are asking for those things and saying, what is it that you're looking for with the extended cultures? Are you just wanting to be extra sure, like, of just a general, you want the cultures to be longer because you perceive that to be better? In which case it's saying, well, actually, that's probably no better, and the things that are growing later on are more likely to be contaminants anyway. which are just causing extra work, waste of resources, and wasting your time? Or is there a specific thing that you're worried about with the extended cultures? In which case, looking at that, and I think there's some studies now that saying stuff like typhoid, you don't really need extended culture because actually with blood culture systems, it grows pretty quick. So yeah, I guess that's the understanding piece, isn't it? Like if people are asking for unusual things that fall outside what we normally do in the lab, it's going back to them and saying, why are you wanting that? And maybe they have a point, like maybe they know something we don't, but I imagine most of the time if they're asking something odd, it's because they don't really understand why it is the way it is or what is being done.
Yes, yeah, I do. I mean, yeah, of course, it's just not generalizing for any reason. I mean, definitely, again, like I said, some physicians they request some cultures and they're already on point because they're strongly suspecting something or they know and they're definitely and they end up being correct. What they were suspecting is what shows up on the culture. It's always that's very amazing for me. And especially when they're suspecting something and it comes out. But yeah, it's just a lot about learning, how everything works. But having said that, definitely all of you, if any physicians out there and you're listening, and any other healthcare workers for that matter, definitely thank you for the work that you have done. It's just, it has been definitely 2020, 2021. There were some rough years, but we all pushed through. And then at the end, we work for our patients. So thank you, everyone.
Well, I'm just going to throw that thank you right back at you because, obviously COVID was a huge pressure on laboratory resources and managing new levels of samples. And, I think patient facing roles, as we said, we'll get that thanks to the patients, but often the lab team miss out on that. So,
Yeah, I actually, and I mentioned this on another podcast that I was talking, and I switched jobs like in February of 2020. So I found myself in a COVID protocol in a brand new place that I had no idea how things work. And that was very rough because it's something, you've been in a hospital for 9, 10 years. So you know how it works. So you're comfortable, the people, the process. So when you go into crisis mode, it's still difficult, of course, but at the very least, it's like a family. So you know them and you get through it together. So that was an intense feeling of finding myself in a different place with all that stuff going on. I mean, ultimately, I came back to my family and I'm very happy. So I'll stay where I'm at.
great.
Okay, so as far as your podcast, we see out there that either, we put our stuff on social media or episodes. So what are your expectations for your podcast?
Yeah, I guess it'd be good to hear James' thought on this, but I think we've spoken about it, and our expectation is to be sustainable more than anything else. It is a lot of work, and you can sometimes feel that imposter phenomenon about like, oh well, we could do this and this would be better, and like, there's asks from people about stuff, and I think we're probably just about as much as we can manage, which is putting out an episode about every 2 weeks. And I guess our expectation would be we'd hope to continue putting out an episode about every 2 weeks and just work our way through all of infectious diseases, which is no small task, and just keep working through bacteria, talk about some viruses, talk about some fungi, talk about some parasites. I think there's unlimited number of episodes that could be made, so we'll just keep doing it as long as we're enjoying it and people are enjoying listening to it.
Yeah, there's definitely enough material, and I definitely I feel what you're saying about, yeah, keeping it sustainable. I publish weekly and it's it's intense. Yeah, it requires, yeah, stay at a level of organization or thinking ahead, or especially, okay, I'm thinking maybe 2 or 3 weeks ahead. Okay, I have enough material here, or maybe I should start writing an episode, or if not, do I have a guest coming over? And that those they help out to keep the continuity. But yeah, it's definitely keeping it going. But of course, sometimes, I just like we don't do this just like you have a job outside of podcasting, so do I. So it's just finding the time, and sometimes, there are life matters, and so I do publish weekly, but like during the holidays I do take a break, and then during the summer as well. And if anything is getting too complicated, like maybe I have a deadline at work or I have something to do with my students, or I do tell the audience, this week there's not a new episode. I mean, I try to avoid that as much as I can, but sometimes, it will happen, but, just, life happens.
Yeah, we don't explain our absences. We just sort of drop off the podcast right there. But I think we're probably, because there's two of us, it's maybe slightly more difficult to schedule because you can just schedule yourself whenever you want, I guess. Whereas we've got to fight through other commitments and so on. So yeah, sorry that we just disappear sometimes, but we'll try to be sustainable and try to keep going as long as people want to listen, I guess.
Okay, so yeah, so if you're publishing like just like we don't get that done week, yeah, I do try. I don't know, it's just like yeah, I don't know if people are constantly listening. I mean, I do get a fair amount of listeners, I will say, but I don't know if they keep track of what I'm saying, no new episode or no new episode. It's just something for me that it feels like since I'm putting content every week and that's the way it's been established, if there's gonna be a deviation for that, then maybe.
No, that's very good. I think that's admirable, and maybe we should aspire to be that uh, thoughtful for the listeners. But I think we're just we'll do what we can do, and that's all we can do.
Yeah, yeah. Okay, so what are the next steps for your podcast? And any future plans?
Yeah, I think next steps. We've not actually had any guests on yet, and so we'll be bringing some guests on soon, which is really exciting. And we were thinking about how to share our resources because we do like a prep and make some notes. So we've started sharing those, but I think it'd be great if we had a slightly better way of sharing those rather than just a shared folder with some notes. But I guess we're constantly weighing up what would be excellent for the podcast and what is sustainable and possible for us to do alongside lots of other things. And so the main future plan is just to try and work through things that people find difficult and uh, give people a resource, hopefully a sort of digital textbook in a way that they can go back to when they're studying for exams or just generally interested that they can listen to. And doing more of this sort of stuff as well. I like more collaborating and meeting new people, as you said at the beginning, is one of the real joys of doing this. People getting in touch and giving feedback.
Yeah, definitely. It's been so great. Normally without this, I mean, especially like I don't think I would have been in touch with so many people from some different places unless I go to a conference or something. So yeah, it's definitely been a great journey and continues to be so. Learning, meeting people. So I do enjoy doing this. So definitely, it's Callum, it's been great having you on the podcast. So thank you so much for taking the time to come to Let's Talk Micro.
Thanks very much for having me, and we'll need to be having you on Idiots soon.
Yeah, definitely, I will like that very much. So thank you for the invitation. And so where can listeners find your podcast?
I know that on your podcast you tell people the exact places to find it. I'm not sure, so have a look. It might be on the podcast player of your choice. I think it's on most of the main podcast players.
Okay. Well, it's definitely on Apple Podcast. That's where I found you. So definitely Apple Podcast. You search it, even if you type idiots, it will pop in. And I found it there, but it was because I found you on Twitter first. I think someone either retweeted something at the time, and then I saw the name, and I decided to look you up on Apple Podcasts, which is the one that I normally use. They have no affiliation to this podcast. It's on my phone, and it's the one that I use the most. But yeah, definitely on Apple Podcasts.
Yeah, if you go Twitter, we've got it's idiots underscore pod, which took me a surprisingly long time to memorize, even though it's very simple. And on our bio, there's a link to the website that they're hosted from. Is you can basically link to any player from there. So that's probably the best way to find it.
Okay, definitely. And I'll go ahead and on my show notes, I will put some links that way the audience can find you if they want to listen to your podcast, which I do recommend. So go ahead if you want to, especially if you're looking to learn more, a little bit about the antibiotics and what they treat patients with and what's used and what's not. It's definitely some great information. And those of you that are biomedical scientists out there and you're looking to build up a little bit more your knowledge, that's definitely a great place to start. So I recommend it.
Thanks.
All right. Well, thank you so much. And that, my dear audience, it's the end of this episode. I hope you enjoy listening and learning about the Idiots podcast with Callum. I definitely enjoy my conversation. It is always great learning, knowing more about what happens with the results that as biomedical scientists, as medical laboratory scientists, what happens with those results, how are they applied to the care of the patient. Definitely, I enjoy talking to a fellow podcaster that has the same objective as I do, which is, educating, providing information. Ultimately, this makes us so much better at our jobs. So definitely check their podcast. I will put the link to it on the show notes. As always, continue bringing that passion to what you do. It's so important. So, as always, stay motivated, stay safe, and of course, continue talking micro. Until the next time. Bye.